Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of 10 Clinical Minutes is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represent those of the participants and not of any of our affiliated institutions. Also, a big thanks to Justin Kugel for his editing, support, and creative contributions.
Thank you for joining us on 10 Clinical Minutes. We've been learning so much through this whole process, and we are so glad to have you learning alongside with us. Now, let's get to the episode.
Good morning, everybody. Welcome back to another episode of 10 Clinical Minutes. This one is a follow-up, actually, of our outpatient diabetes Decoding DX session that we did just about a month ago. In that, we talked a lot about diabetes management, some of the complications of outpatient care, but we didn't really get into the medications and which agents you do when. So this Clinical Minutes is addressing some of those unaddressed questions. Here we go. So first off, we have this helpful graphic from the CDC about what is the definition of type 2 diabetes. You can see here on the left side that you have diabetes, prediabetes, and normal, and then 3 different tests: A1C, fasting blood sugar, and glucose tolerance test. With these tests, always remember there are things that can cause false positives, there are things that can cause false negatives. And so variability does exist. There's also variability sometimes in the testing measure. For example, capillary glucose is different than a venous glucose, is different than arterial glucose. But by and large, these are going to be the standard metrics that you see to define these 3 terms, with an A1C being the most validated. And that being because it's the 3-month picture of glycation end products in your body. The A1C can be disrupted by several different things. We talked about that some in our discussion about a month ago in that outpatient diabetes case. One of the most common will be anything that increases red blood cell turnover falsely drops the A1C. Anything that decreases red blood cell turnover falsely elevates. But with all of these, another thing to remember is that treatment's important. Diabetes has complications. We have treatments for it. We need to take care of it. And then close follow-up with patients is needed. This can maybe monthly visits, so maybe every 2 months, every 3, and at a minimum, really every year. And someone who's well controlled will probably be coming in about that frequency, or every 6 months. And then lastly, these labs can motivate change. A lot of times change is difficult to inspire in our patients, but whenever we have objective data, sometimes that's more effective than just saying, I'm concerned about this. And so sometimes these labs can motivate a lifestyle change or a diet change, or adherence to medications that would otherwise not be possible. So our first line therapy for diabetes is lifestyle changes right here, which kind of fall into 3 main buckets: medical nutrition therapy, weight loss, and exercise. References are indicated here by the number, and then the last slide has the numbers correlated to where the information came from. So then with the goals of intervention, this kind of categorizes for each one of these what we're shooting for. So for medical nutrition therapy, we want to reduce intake, address the lifelong patterns and habits that are affecting how the person eats and what they eat, and then promote a catabolic state where some of the excess energy storage can get turned into energy expenditure. For the weight loss, we really want to reduce insulin resistance, and we also want to promote catabolism. And then exercise, we're increasing expenditure, but also we're increasing insulin sensitivity without insulin. That's some interesting physiology. You probably learned it or discussed in the first couple years of med school. Go back and look at how exercise increases insulin sensitivity. So then this last column are just different options that could be recommended. There are multitudes for each of these. These are just some of those. This is not by all means conclusive. And then each of these would have more subsets that we could talk about in each of their own individual 10-minute sessions. So we're not going to dive too far deep into the weeds. The first one with medical nutrition therapy, I wanted to talk just a little bit more about today, because it's kind of a black box. It's all over the place. And so you could ask, caloric restriction works, but some people have seen that changing the macronutrient content works independent of caloric restriction. Or you could talk about intermittent fasting, time-restricted feeding has the same efficacy, but other people have great effects without those. Carbohydrate restriction, fat restriction, high protein diets, all of those have been shown in independent studies to have some efficacy. And so there's a lot of heterogeneity within the patient in terms of what nutrition therapy will work for them. In general, caloric restriction, periods of time without eating, which kind of resets the metabolic clock, and carbohydrate restriction have a large volume of evidence, but there are outputs and data sources that show that those things aren't necessarily necessary for a patient. Which brings us kind of to the next piece, which is in our treatment, we have to keep the patient in mind. So you could ask, when's the best time to schedule medication? Is it morning, nighttime, after meals? And honestly, the best time to schedule medication is when the patient will take it. There are exceptions, obviously, in medication like short-acting insulin has to be taken with meals. Or you could ask, what's the best kind of exercise to recommend for our patients? And the answer is whatever the patient will repeatedly do. If you want them to do high-intensity interval training and they're never going to do high-intensity interval training, you can recommend it as much as you want, but it won't happen. And so you're better off getting the patient to do something rather than to do the specific thing that you seem to think that they will most likely benefit from. And the last one, what's the best dietary change to recommend? And it's honestly whatever the patient will start and continue. And so if we initiate changes for our patients, but we don't keep the patient in mind, then we miss the point. And we're probably going to advise them to do things and spend time counseling to do things that they don't actually have a desire to do, and thus will not have good effects of sticking with it. So once you pass the lifestyle changes, you can kind of move into the medication. And sometimes, honestly, depending on where the A1C is at, all of this will happen at the same time in the same visit. If you have a borderline A1C, 6.5 to 7, low 7s, depending on how well you know the person, you could just start with lifestyle changes, but you really wouldn't be hurt by starting to onboard someone with metformin. By and far, this is the first medication you start with lifestyle changes. The dosing is over here on the right. You start them out at 500 milligrams once a day. And the goal is to get them up somewhere between 1,500 and 2,000 milligrams, broken up into 2 doses daily. That can be either an immediate release form, which you take twice daily, or it can be an extended release form, which you just take once daily. The extended release form seems to have a little bit better adherence in regards to the side effects. And part of that is because you're getting it all in one dose. You're not having it repeated throughout the day. And then the other part is that you take it right before you go to bed. And so some of those side effects you don't experience because you're sleeping. These are the tablet sizes that are available: 500 milligram, 850, 1,000, 500, 750. And you just kind of work your way up slowly with folks every 1 to 2 weeks, increasing by about 500 milligrams for the IR dosing. And the IR and the ER are equivalent. Considerations: if somebody has poor kidney function, GFR less than 30, that's an absolute, you can't do it. The risk of kidney complications are too high. And if it's GFR 30 to 44, then you can titrate how much you upregulate the dose, but be more aware of the side effects. Most commonly, the GI. Also, less known B12 deficiency, check that once a year, and lactic acidosis, which is the historic board question, but does actually happen in clinical practice. And then once you start somebody on medication like this, you want to follow them up. When you're onboarding them, you follow up more closely to monitor for side effects. And then after they get up to an effective dose, then you monitor every 3 to 6 months, rechecking the A1C, checking the creatinine, checking the B12, in addition to the other regular components of a diabetes outpatient visit. After that, you get into the weeds a little bit with these second medications. So you start with lifestyle changes in metformin over here on the left. And then if somebody's at high cardiovascular risk, you really want to go with the GLP-1 or an SGLT2 inhibitor. Those have good evidence showing that they reduce cardiovascular outcomes, improve patient mortality even. And then you have your cost considerations, which takes you to some of the older agents, the sulfonylureas or the thiazolidinones, also known as TZDs. Then you get into the hypoglycemia category: GLP-1s, SGLT2s, DPP-4s, and TZDs that don't actually increase the risk of hypoglycemia. Sulfonylurea does increase that risk. And lastly, of your weight considerations, both GLP-1 and SGLT2 have been shown to be fairly effective for weight loss. GLP-1 through a mechanism of decreasing intake, and SGLT2 by actually urinating glucose. So just some tips for these second medications. I'm not talking through everything on this table. We're going to leave it up here. Pause the video, take a look at it. The prices in red and green are the GoodRx rough averages for 1 month worth of prescription. As you can see, the newer agents, the SGLT2s, GLP-1s, and DPP-4s are much more expensive than the sulfonylureas and TZDs, which you can get for pennies on the dollar compared to them. Metformin falls into that significantly cheaper medication where someone can get a month's supply for $4 to $10. But some of the side effects of the SGLT2s and GLP-1s is this weight loss, which is actually a treatment benefit. And then of these, the most common administration for GLP-1s is this IM dosing. But this year, there's released one oral dose that is, at least in the pharmaceutical studies, seen similar efficacy. The difference being that it's dosed every day and you have to take it 30 minutes before you eat breakfast and then wait. Whereas the IM, you just dose once weekly. So for some people, that once weekly dose is really a benefit. For other people, not so much. The SGLT2s we'll spend a little bit of time on. They are GFR dependent. Low GFRs are less effective, but they slow the progression of kidney disease down here. And so they actually can help maintain the GFR for a little bit longer. It's also blood glucose dependent. If you don't have a high enough blood glucose, you don't have glucose being filtered through the kidney. If glucose isn't being filtered through the kidney, preventing its reabsorption is ineffective. And then lastly, it has an independent benefit in congestive heart failure in improving cardiovascular outcomes, independent of whether or not the person has diabetes. And so this is a medication that you'll start to see prescribed more and more for non-diabetic indications, which may hopefully start to bring down the price a little bit. This sulfonylurea, it's a common historic treatment prescription. And so folks will be on it. And you can ask the question, should they still be on it? And if they're at risk of hypoglycemia, then you should probably take them off it, especially if they're an older patient who's gone on it for many, many years. After you go through the second medications, a lot of times you'll either add, mix and match some of those, or you'll start to move towards insulin if the person's showing that they need it. We'll talk about this in another conversation about basal, bolus, sliding scales, and correction factors. That's beyond the scope of our discussion today. So lastly, folks want to know, how's this going to affect my A1C and how's this going to affect my weight? Highlighted in green are the ones that have really good effects. Highlighted in red are the ones that are concerning. So as far as weight change, we talked about it. GLP-1s and SGLT2s have the greatest decrease in weight. Metformin up here, you'll see, is minus 10.1 all the way to 0.8. Great variability. It does cause some weight loss, but it's not commonly used as a weight loss medication. But then the sulfonylureas, TZs, and insulin all increase weight pretty significantly. Insulin's the most effective at decreasing the A1C, but it comes with that weight gain, which ends up increasing the amount of insulin that you need. And then you'll notice that a lot of these kind of fall in the less than 1% range or right around 1%. GLP-1s get up to the 2%. Personally, anecdotally, have seen some patients lose 2 to 3% on GLP-1s. But it's the one that stands out the most from an A1C perspective, and that's because it actually decreases the intake. And so all the rest of them, you can expect to get roughly 1% of an A1C change. And so that's why you have to couple it with lifestyle changes. Because if someone comes in with an A1C of 9, you're never going to get them to goal of less than 7, right around 7, with just 2 medications, especially if they fall on the lower end of the spectrum of the 0.5% change or 0.4% change. So what's the real problem? Anytime we're treating something, we're not just treating a disease, we're treating a physiologic process. And so 2 main buckets that fall into for diabetes is hyperinsulinemia and hyperglycemia. Which of these is primarily responsible? It's a good question. We don't actually know. There's various contrasts in the literature of if one causes the other, if the other causes first. But hyperinsulinemia causes storage. The excess storage of fat causes insulin resistance. It also causes hypertriglyceridemia, which causes a lot of the problems associated with hyperglycemia, especially the macrovascular complications. And so it kind of begs the question of, is this why our insulin requirements increase when patients start their insulin? It's because they're actually worsening their disease process while artificially improving their A1C and their glycated hemoglobin. And we might very well be doing that, and that might be why the insulin increases, which really points to the fact that you want to treat this disease with lifestyle modifications. And that's why it remains first line to hold somebody off on moving to insulin as long as you can, because it will help with these macrovascular, microvascular complications. But it only seems to then put someone on a progression where they continue to worsen in the disease course because they're only increasing the insulin that's in their body. So just a couple of things really worth looking into. I would love to know the answer of what the real problem is. Unfortunately, I do not know what it is, and the literature is not clear yet on which of these comes first. Key points: treatment, lifestyle change, metformin, SGLT2 or GLP-1, weight loss and carbohydrate restriction attack the core of the disease, which is excess energy intake. Know the high points of the meds and what to do with them and which ones to prescribe when. And then insulin helps with the hyperglycemia and improves some outcomes, but it does not solve the problem of diabetes. Here are my references. If you'd like to have one of these and you cannot find it, please contact us, DecodingDX, info@decodingdx.com, and we can get this information to you. Thanks so much. Hope you have a great day, and thanks for tuning in for 10 clinical minutes.